Yes.
Yeah.
Great, thank you. So again, everybody, thanks for having me do this. I was mentioning earlier, I got getting over a case of laryngitis, so I may be taking pauses every so often to clear my throat, and I apologize for that. And this talk was a recent invitation. So this is kind of, I'm going to be sharing what I know within the context of my own practice and research, as well as what research is out there. I'm looking forward to the Q&A where we can really talk about some of the practice and actual what I do and others. And I'm glad that Greg can be joining as well, so we can really kind of have more of a dialogue as well about how to do this well. But I was tasked with talking about why pronouns matter. And I feel like the short answer is, you don't even have to see the presentation, is this is about respect. And this is about providing competent and compassionate care for everyone. Everybody really needs to learn how to do this well. So I'm going to put my educator hat on and kind of be a little bit more didactic for the moment. So naturally, disclosures, I do not have any disclosures. I'm a primary care doctor and a professor. We're not here for the money, as it were. I think I always like to start with a land acknowledgement. We in Boston are on occupied lands, and I think it's really important to recognize that some of the first steps in creating change is acknowledging past grievances and offenses. Moving on, so talk briefly about the objectives. I'm going to talk broadly about the context of LGBTQ individuals, lesbian, gay, bi, trans, and queer. Because a lot of what we talk about pronouns has been couched within the term issues affecting LGBTQ persons. But like I said, pronouns are a matter for everyone, so not just LGBTQ folks, but that is the frame I'll be using. I'll talk briefly about the evidence that correct pronoun usage actually protects people's health, or that using incorrect pronouns or misgendering individuals is deleterious to their health. I'll talk about some of the theory behind that, as well as the evidence that fits into that theory. And then, of course, talk about a few different steps for how to improve our own practice, both clinical as well as just daily human interaction. So, within the broader context, I'm happy to say that the National Institutes for Health really is supporting research as it relates to sexual and gender minority individuals. SGM refers to not only LGBTQ, but also other identities that essentially do not fit into society's preconceived binary notions of sexual orientation, gender, or sex. This is their official definition. This is something that I cite in all my NIH grants because it really drives home the point that these are populations that have been overlooked and ones that we need to build up our research on. And to that effect, I would point out just earlier today that the National Academies of Science, Engineering, and Medicine released their 300+ page report as an update on understanding the health and well-being of LGBTQIA+ individuals. So again, doing this work is not only the right thing, it's also strongly encouraged by our national organizations. So. The terminology, I like to really use this kind of graphic that gets away from thinking about things in opposition as if everything is masculine versus feminine. It is not that in reality across our society and others. But these kind of categories really kind of drive home some of these points. I'm going to focus on the top ones first. So gender identity, internal sense of gender. This has often been described as internal sense of being male or female, but I more prefer to say it's just your internal sense of your gender. It's who you understand yourself to be as it relates to the social construct of gender. Gender expression is how you use social and cultural cues to express that gender. And I think it's important to recognize that there's a significant component of social and cultural context as it relates to this. What might be seen as feminine in one society or cultural context may be seen as masculine in another. I always think of the time when Jacob Tobiah, a gender non-binary advocate and author, came on the Daily Show and provided an earring to the cisgender man who was the host, to Noah, and Trevor Noah. And Trevor Noah goes on to say, "My grandmother would be so proud because wearing an earring is a sign of masculine expression in my culture." So again, recognizing that context is really important here. I like to think of gender in this kind of nested model. We're very used to learning about sex assigned at birth in medicine in terms of male, female, and that's it. We know that is actually not the correct way to approach sex assigned at birth, and that we know there are a number of other designations as it relates to sex assigned at birth. Gender identity relates to sex assigned at birth, and then expression overlays that. And then how people react to your expression or is what we call perceived gender. And that's where a lot of what we're going to talk about resides in terms of how are people and society responding to their perception of your gender and regulating potentially your body as it relates to that. Before I go into that, I do want to provide, there is a lot of historical context to understand that this is not new. While International Pronoun Day, I believe this is only the third year it has been around, somebody can correct me if I'm wrong, addressing multiple identities as they relate to gender is not new, and it is something that has existed across multiple cultures for centuries at this point, in terms of at least what we can confirm within the historical record. Trans Bodies, Trans Selves, a wonderful resource compiled and written by trans persons, provides a good context and overview of, at least within the U.S. Historical context, of different identities beyond man and woman as it was understood at that time. Written by Jenny Beeman, who's a scholar at Harvard. Some of the earliest depictions of colonial interactions with indigenous societies really highlight that there were multiple cases of people essentially having gender expressions that did not fit Western colonialist binary categories of man and woman. Sometimes they were assigned based on sexual orientation, using derogatory terms as it relates to feminine men and the like. But we know that many cultures, even within the North America, had multiple genders. And here we have a Zuni Two-Spirit in a photo that was believed to be around the early 1900s. Wiwa, described as a Zuni Berdache, weaving essentially. And Wiwa was one of the more prominent Two-Spirit individuals within their tribe at that time. Not only are native indigenous cultures home to a lot of what we understand for early non-binary categories of gender, we also know that this has also existed within even colonial societies. So this is Mary Henley, in Middlesex County, Massachusetts, who was arrested in 1692 for wearing men's clothing, which was, quote, seeming to confound the course of nature. So again, society tried to essentially regulate. They tried to make Mary wear men's breeches and women's aprons and cap to really kind of address their skewing of gender norms at that time. It did not, unfortunately, go well. Again, kind of society regulating within binary categories that really are quite restrictive and not acknowledging the reality of how people live. There's much more in the historical context. This is a recent publication by Jen Mannion, who's a historian at Amherst College, really looking at the existence of what people labeled as female husbands within newspapers, essentially people who were assigned female at birth, living as a category of husband within relationships. So again, recognizing that what we think of as gender as strictly man, woman, and binary, and the different expressions of that has not been the truth of the matter across history. Naturally, I think it's important to talk about the actual numbers. I had some questions put in early where people were wanting to understand why we need to do this. There aren't that many people who may use pronouns that do not immediately, as they think, fit their assumptions. I would highlight that based on the behavioral risk factor surveillance system, which is one of the largest, oldest surveillance systems of its kind in the US, provides a decent estimate of the adult trans population and the adult population where pronouns definitely would be an issue that we need to be cognizant of, at about 0.5% of the population. This prevalence of trans identities in adults in the US, I think, is a decent estimate. It's fairly consistent across other studies as well, but I think it also highlights that this is a large population. 0.5% is actually much larger than a lot of the other things we have to learn about within health professions training. I know intricately about congenital adrenal hyperplasia, which affects 1 in 10,000 individuals. Here we're talking about a population that is essentially 1 in 200. So I think people need to recognize that they are going to encounter trans and gender diverse persons in their practice, and it would be naive to think otherwise, honestly, at this point. And I bring that up more so as well as because the population of people who identify as LGBTQ is getting larger, not because that more people are becoming LGBTQ, but because society is getting better for people to actually feel comfortable coming out. There is more support for LGBTQ individuals as time has gone on. And there's been great research that looks at across different generations, the age at which people recognize that they have their sexual orientation or their gender identity. It's fairly consistent across generation. It's the age at which they come out that varies, which is kind of a proxy for how society was welcoming or not. This, digging a little bit deeper into this statistic here from GLAAD, really highlights that we see that trans and gender diverse identities are also a larger component of younger populations. So again, I think people need to recognize that providing competent, compassionate care for everyone is going to involve some component of training as it relates to gender and gender affirming care. So I just want to drive that home here. And also, of course, we're in Boston. We're practicing in Boston. This is based on our state's behavioral risk factor surveillance data, looking at neighborhood level essentially, and looking at the prevalence of LGBT adults within Boston. Boston from 2010 to 2017 had essentially a prevalence of 8.2%. Boston tends to rank a little bit higher than a lot of other cities in the US. And I myself live in JP, coming to you from JP, we're about almost 14%. So again, recognizing that broadly LGBTQ populations are a population that you're going to be providing care for. I want to talk about essentially then how pronouns and generally stressors could potentially affect people. I'd like to frame this within the minority stress model or minority stress theory, which has been very well characterized since the 1980s, has been very well explored and continues to be explored within racial and ethnic groups as it relates to experiences of discrimination and downstream health effects. It has since been retooled to apply also to sexual and gender minority persons, so LGBTQ persons, and really trying to think about it thematically is the idea that your identity feeds into how society responds to and distal or external minority stressors. We know that there have often been state and national regulations as it relates to sexual orientation, gender identity. We know that that then can filter down into how people are actually treated in specific hate crimes. The disproportionate number of trans women of color who are murdered and such fall into this kind of category. And the basics of essentially institutional discrimination fall into this as well. A lot of that can get internalized into internal homophobia or transphobia, essentially self-hate, but also can be internalized in a way of being vigilant. This constant need to be on your guard and be prepared to deal with any kind of potential stressor coming your way. This constant chronic vigilance leads to chronic stress, which has physiologic effects that eventually lead to downstream health effects. We've been doing a good job of trying to characterize this within cardiovascular disease, since that is a series of conditions that are very well tied to stressors. So we're really trying to characterize this better. So as I present some data around misgendering and pronouns and the proper use of pronouns, I want you to think about this theory, as it were. The slides I'm happy to have shared. So some of the slides I'm going to go through quick because I've just talked about them already, essentially prevailing framework for how we think about this. Again, what are distal and proximal stressors? But again, highlighting that there's growing evidence for how various stressors could affect certain behaviors and subjective and objective health measures. So notably, experiencing multiple forms of discrimination, whether it's interpersonal or policy level, is associated with depression, anxiety, suicidality among LGBTQ adults, particularly a stronger effect as it relates to LGBTQ people of color and bisexual people. And then, of course, any gender-based discrimination has been associated with depression among trans individuals, and then any kind of family rejection, early loss of support from the family has been associated with increased attempts at suicide. And early loss of support or rejection is also rooted as it relates to pronouns and using somebody's name correctly and kind of recognizing their gender appropriately. Again, issues with discrimination affecting behaviors in terms of leading to increased poor coping mechanisms such as tobacco use and drinking across multiple categories. And then, of course, we're still trying to get more evidence as it relates to actual objective physical health. That's being said, we have seen that policy level changes do affect population level issues. So when Massachusetts was one of the earlier states to legalize same-sex marriage, we had a natural experiment essentially to look at particular health outcomes among SGM populations within the data. So from compared to before to after same-sex marriage, gay and bi men had a 18% reduction in rates of hypertension or needs for medical visits for hypertension. We have measures of sympathetic nervous system activation that have been found to be dysregulated in terms of self-reported exposures to discrimination. This has been seen within lesbian and bisexual women. And then, of course, we're seeing more issues as it relates to effects on youth. Again, measuring that LGB youth who experience discrimination have a blunted stress response since they've been exposed so many times at this point. And then, of course, again, seeing the benefit of policies that are protective and recognizing individuals, and the nature of the negative effects of structural discrimination, such as exclusions as it relates to gender identity, exclusions as it relates to access to gender-affirming care, and the like. I want to talk about how this fits into the larger policy context. I think we have the benefit of being in a fairly progressive state. That being said, that is not the case for all of our patients or all the people we're going to care for, or where we may end up practicing and doing the work that we do. So I want to highlight some of the differences across different jurisdictions here. Again, recognizing issues as it relates to being able to change your name. So how the state regulates the ability for people to use their correct name in their documents, including not only driver's license and the like, but that stuff trickles down into people's insurance cards. And when insurance cards are involved, that also can affect how they are able to access gender-affirming care or any kind of supportive services as well. And I'm talking very specifically about gender-affirming care for trans folks, but also it affects any kind of care, not just that's specific to their gender identity. So here you can see that Massachusetts still has some unclear regulations as it relates to being able to change your name, whether you have to publish in a newspaper or not. There's some issues with this because it's requiring people to essentially out themselves when they want to try and just update their documents. A bigger issue, of course, as it relates to birth certificates, being able to change the name or gender marker on a birth certificate to reflect somebody's gender identity. Some states had previously required a letter from their doctor saying that they had gone through specific surgeries. We know that's not at all how this really works. We've thankfully been able to change policy within the American Medical Association saying that between a patient and a physician, it is a case-by-case discussion, and that there should be no surgery requirement to be able to update somebody's gender marker. And ideally, it really shouldn't necessarily require a clinician to weigh in on this, but some states will do so. And then as it relates specifically to youth, who I think are most vulnerable to issues as it relates to misgendering or pronoun misusage, these are the state laws as it relates to any kind of affirmation or protection for LGBTQ individuals. So you can see in magenta, these are states with very specific non-discrimination laws that explicitly prohibit discrimination against students on the basis of sexual orientation, gender identity, and then there are some specific state agency guidances as it relates to the care of transgender and non-binary and gender non-conforming students, which includes training around proper pronoun usage. But then here again, this is as it relates to education for students, LGBTQ content specifically. While the dark blue are states that now require it as part of their public school curricula, there are light blue states that do not, that actually explicitly exclude this. So, and then this is the issue as it relates to bullying. So states that provide protections against bullying based on sexual orientation and gender identity is yellow, but we have two states, magenta, that prohibit school districts from allowing the explicit inclusion of sexual orientation or gender identity in their anti-bullying regulations. Currently, the current administration has explicitly tried to provide coverage for discrimination against LGBTQ individuals, essentially allowing clinicians to turn away LGBTQ folks based on deeply held moral or religious convictions. So again, another significant policy level concern. What I want to get to explicitly here is what data we do have as it relates to correct pronoun usage. This is a survey of trans and gender diverse youth, specifically asking, do they want this information even in their electronic health records? Thankfully, we, as you can see, a large number of folks actually want to make sure that the EHR or the EMR, the electronic medical record, correctly uses their name or their pronouns Not surprising here, really, that this has come out. And of course, there's a big issue in terms of how out they are to anybody, whether they want this information there. I will say, thankfully, that across Boston Medical Center, that our electronic health record does allow people to put in their correct name, as well as the pronouns that they would like us to use, and that this carries over into a lot of our pre-filled forms. That being said, it's not a perfect system, and we're still trying to meet the needs of our patient population. And then more specific to looking at a cohort of trans and gender nonconforming youth from urban settings, we did see that there was some issues as it relates to correct pronoun usage. So after adjusting for a number of particular personal characteristics, including age, race, ethnicity, and the like, using the correct name, using the person's correct name and not misgendering them led to a self-report of fewer depressive symptoms, less suicidal ideation and suicidal behavior. But they noted that it was kind of a dose response for the number of times that they could recall being misgendered or having incorrect pronoun usage, that there was an increase in depressive symptoms or an increase in suicidal ideation. The opposite being said, that by doing it well, actually led to some protective effect, at least within this data. And this is from Dr. Russell from UT Austin and their LGBTQ policy and advocacy research lab. There's more data that's coming out in the next few years, and I know actually 1 or 2 in the next year, that really are highlighting that the issues related to pronouns and misgendering individuals does have deleterious effects on subjective self-report of health. We are still trying to tie that into the larger context of how does this affect larger downstream health conditions. But honestly, I feel like I don't need to wait for us to find a deleterious effect to make sure that we change behavior. Respecting people and using the pronouns that they tell us and using the names that they tell us is really critical. And again, it kind of fits into this larger model of minority stress. And recently there was a report from the American Heart Association highlighting the larger context of cardiovascular health within LGBTQ populations. And a part of that was this discussion of minority stress and misgendering as well. So I want to highlight that. Now, I want to take the next few minutes to really talk about what can we be doing better and really what's the usage out there of pronouns. So this is based on the US Trans Survey, one of the largest surveys of transgender individuals in the US ever to date. And they really highlight the pronouns that are used across their cohort. And you can see here, not only are they using the binary pronouns such as he and him, she and her, but also they and them as a gender nonconforming, gender non-binary pronoun, but also he and here, and additional pronouns as well. We know that being able to use the correct pronouns is considered part of family support and also just general support. I'm highlighting here that some folks are just not have the opportunity to be around supportive adults. And I think it's something that we really need to be stressing within our own training. And I bring this up more also that this is something that our professions are acknowledging. The AAMC now includes honorifics that are without gender binary, that are allowing people to update that information. We know that they're also allowing the opportunity to select very specifically pronouns within their own data to really honor the diversity of students that are coming through medical training at this time. We've done similar work within the American Medical Association to again recognize that our medical profession is thankfully becoming more welcoming and more diverse, and that we need to really respect and honor our members and our future colleagues as it relates to pronouns and names. I did see an earlier question as it relates to some other pronouns. People are familiar with the gender binary pronouns of she, her, hers, or he, him, his. I think people don't realize how comfortable they are with they, them, and their already, since oftentimes if we don't know who we're talking about them, even though they're an individual. It's the same thing whenever anybody says that their pronouns are they, them. You just got to kind of click into your autopilot about using that. It just takes some practice. There were some questions about in the flyer itself, what Z and here are. I think these are, this is a helpful slide just because it also includes pronunciation, because some people feel a little intimidated by seeing the words but not understanding how to say them. But again, these are other pronouns that are out there that are being used more widely, as you saw in the US Trans Survey. That again, patients and people you interact with will share this information if you allow them the opportunity to share this information, and you will learn from them. I treat it the same way as learning somebody's name. And honestly, like I can't hear every name and know how to say it correctly the first time around. That means I ask for their patience and that I'm going to learn, I'm going to do it right, and that I'm going to put in the effort to do it right. So I think it's important to recognize that just because it's hard the first time doesn't mean you're not supposed to do it. You're supposed to get this right. And again, I want to really highlight this notion of they as a proper pronoun. This has really come up multiple times. A lot of organizations have recognized this. The American Dialect Society has chosen they as their word of the decade. Merriam-Webster has included they as the word of the year. And that this is really becoming more acceptable. And not that it had to be verified by anybody, but recognize that there is a significant cultural shift to recognize that they is appropriate in the singular form. And it only takes a little bit of practice and you'll get there. So some key steps to really work on are, I think, introductions, kind of like when introducing yourself, saying what your pronouns are. You can also, in meetings, you can also offer the opportunity to share that, but also not require it. I think it's important to recognize that you create the space, but that you don't require anybody to answer that question necessarily. So again, and also recognize that if anybody is confused or takes offense, it's pretty much standard. It's the same way I approach this, the same way I do any other of my queries or questions as a primary care doctor. I'm asking everybody, and this is just part of my standard practice. And ideally, this should be wrapped into how we do intake. That it should just be on a form. People would easily recognize, oh, everybody's going to be asked these questions. I'm going to check one box or multiple boxes or no boxes and kind of go from there. Make it routine, as I'm essentially describing, make it routine and structured in everything. I have this in my email signature. I have this actually in my BU profile. BU profiles now have the option of listing pronouns. I have my own ID that very much lists my pronouns. We make sure that other components of the environment are supportive as well. So that includes all gender bathrooms or gender neutral bathrooms. And then the big thing, of course, is just practice and just making it part of your everyday is really important here. So whenever you have a meeting, if you have name tags, you should probably think about including pronouns on part of those name tags, making sure that it's part of any kind of conference that you're including where you're collecting information about people, but really trying to essentially say it out loud when somebody shares that information with you, just so you kind of get it ingrained in your head. Again, same way as practicing with somebody's name, just got to say it a few times and you're going to get there. That being said, you're going to mess up. We're always going to mess up because we're learning something what we feel is something new to us and something that is might not initially feel what we're used to. Don't worry, you mess up. Simply say, like, apologize, get it right the next time, and move on. Don't make a big deal of this. I think a lot of people are very more forgiving than you realize. And while we are taught too much within medicine that perfection is the way to go, this is one of those situations where perfection is quite detrimental. You're going to mess up. Recognize that and just try and essentially move on with some grace about this, as it were. That also means being a better ally. Learn how to support colleagues, be supportive. It's one of those things where I started putting my pronoun in my email very early on, even though as myself as a cisgender individual whose people's assumptions of my pronouns have often been correct, I still put it there very explicitly in my email early on to signal to others that this is something that we should be protective and cognizant of. If you know someone is consistently, whether intentionally or unintentionally, using somebody's incorrect name or pronouns, kindly update them. If you think it is malicious, treat it as any other malicious event towards somebody and pass it up. We should be thinking about protecting our colleagues and our patients in the same way we do from any other kind of form of discrimination. Intentional misuse of pronouns and names, in my opinion, is intentional discrimination and should be treated as such. And then think broadly just about how affirming pronouns can be integrated into our practices. Anytime we're collecting information as it relates to, we need to even update our categories as it relates to gender. Think about including questions around pronouns. If you think about all the communications that we have automatically generated that include pronouns, like when I first moved to BMC, I had to spend at least like a full day within our electronic health record to go through all the notes that are automatically generated when I see patients and update their pronouns, or make them gender neutral, or remove pronouns where it's appropriate. So recognize that there's a lot of binary pronouns baked into our systems, and oftentimes those pronouns are making assumptions pulled from incorrect data. So thinking about all the different ways that this comes up within our system is really important. And it is for those of you who are very nitpicky and small task oriented, this is a really good project to take on. And this is something that I've, in my own unique way, have enjoyed pointing out and addressing as well. And then, of course, just making sure that you have very specific examples for how to do this well. These are examples at the individual level. Again, obvious ones using appropriate name and pronouns, correcting colleagues gently about this, advocating as needed for employees and patients. And then, of course, also just uplifting folks and being an advocate as we would for any of our colleagues and patients. And then, of course, larger organizational level stuff. I think the big one here I like to point out is making sure that the environment is gender neutral, that you think about how insurances are taking in people's correct names, and that how any of your letters that are going out to patients are using correct pronouns and the like. So being very proactive about this. That being said, there's going to be mess ups. Healthcare is messy in a lot of different ways. So recognizing that when there's an error, that's an opportunity to improve, and it should not be taken as a significant deficiency. It's just an opportunity for us to do better. And then again, practice. I like to, as somebody who gives more talks than I feel comfortable than I should, I've had to adjust my own language as well. You don't say good morning, ladies and gentlemen. You say good morning, folks. So glad you're here, and kind of go from there. Or there's a lot of funny ones out there like hello, friends and enemies. I'm glad you could be here, things like that. So try to avoid being overly gendered is really a good way to signal that you're thinking about this and being proactive and being affirming. I've made a lot of time for questions. I want to leave that here. You can contact me, of course, after the fact and what have you. While we're waiting for questions, and Farah, I appreciate you let me know if there's any that come up. I'm going to go through some ones that were sent in advance that people shared early, which is very helpful. I think I'm hoping, so one question, and I'll paraphrase. Some of them were wonderful little novellas, and I appreciate people putting a lot of thought into their questions. But one was the notion of how is this important, and is this potentially an issue as it relates to privilege, since there are a lot of other issues affecting people's health. And I agree that we as healthcare professionals across multiple disciplines are dealing with a lot. That being said, we have to deal with a lot because a lot of things affect people's health. And I really put a lot of emphasis on the minority stress theory because it really accounts for a lot of the social determinants of health, a lot of outside factors and how those factors are regulated. Who has access to housing, employment, who has access to basic needs of healthcare, or even just basic needs in terms of being able to live comfortably, whether it's in contact with healthcare or not. Being affirming, being correct about names and pronouns is a critical component of that. So while yes, addressing life-threatening diseases or hunger or other major issues within society, including racism, this is part of that as well. And I don't think you can do any one of those well without doing this well as well. Another question was, I answered the question as it relates to some of the other pronouns out there. A few questions that were specific to BU that I don't have an answer for. How is BU updating consent forms? This is something I would like for our institutional review board to take up. And there are many opportunities where they could go through their practices to see how are they collecting information from study participants, especially looking at preemptively what applications to the IRB are including as it relates to this. Fenway Health, which is the LGBTQ health center based in Boston, and is a national leader as it relates to LGBTQ issues. I sit on their IRB. Our IRB consults for a lot of other IRBs as it relates to a lot of LGBTQ issues. This is an opportunity to kind of pick our brains and really recognize where can we update this in consent forms to be less gender binary.
Can I comment on that?
Yep.
That was my question. I'm Kayla.
Yep.
Our study is going to be in individuals with PTSD, which high population of individuals with the LGBTQ community have PTSD. And a lot of our study procedures are dependent on if you're an individual assigned female at birth or not because of pregnancy testing. And so that's where my questions are, is how do we address them appropriately in our informed consent, where we make them feel included, but it's also not getting too wordy where every single time we're using individuals assigned at female at birth. Is it okay to say that at first and then say eligible females, where they know that we're trying to be inclusive? That's kind of where my question was, where we can be like, use non-gender conforming. And that's kind of where my questions were.
No, and so that's great, and I appreciate that you're thinking very proactively about this. I think it's important to say it up front, like based on our research question, we are looking at people who are assigned female at birth, and you could say very explicitly that includes, but is not limited to cisgender women, transgender men, and the like. And you could consent forms are essentially almost a form of legal documentation. Say, moving forward, we're just going to refer to anybody who is assigned female as an eligible participant. Just leave it at that. And that, again, and if you need to, depending on how the consent form is being shared, you can easily direct them back to the eligibility criteria. You kind of had your own solution in your question for the most part. But this also gets to the point where, like, I've seen a lot of research where they're like, oh, we're only going to be looking at men. And I'm just like, well, your research question affects everybody. So why is it only men? So what is the motivation for only that? And then how are you actually operationalizing that? Do you mean people assigned male at birth? Do you mean any man? So that includes, that doesn't necessarily mean it's only people assigned male at birth kind of thing. But this is one of those situations where, oh, go ahead, sorry.
I don't know if you've had experience with this, but do they allow like a place to allow them to designate what their preferred pronoun is, like near their signature?
So that is an option. I haven't seen it as part of our standard consent form. It's ones that I've seen from more proactive researchers, and it's something that we're thinking about making standard as part of our IRB procedures. I can't speak to BU specifically since I don't sit on their IRB. One's enough.
Thank you.
Thank you. I'm just seeing some of the comments in the chat, which is great, in terms of just recognizing the diversity of people within Boston and the different definitions of welcoming and not, and then highlighting many opportunities to include pronouns across different categories, including in online profiles and the like. I have it in my Twitter handle, kind of making it easy. So yeah, I think that's all those questions from the chat.
At this time, there have been a couple questions directed towards me and a couple questions that were submitted a little bit closer to our start time, which kind of fall under a similar category. So I'll open it up for Gray and Dr. Street. One of the questions, or a few of the questions, have sort of touched on this topic of how best to deal with or approach a colleague or a superior who might not be willing to go out of their way to educate themselves on this issue, or hesitant to make the inclusion of pronouns more a part of standard behavior, and particularly for people who might also fear perhaps negative repercussions in dealing with those power dynamics.
Great, you want to go first?
Yeah, I'll take a stab at it. So I think what's important is that you don't need to know everything. And that there are a plethora of resources on this topic. You can send them talks like this. You can send websites like mypronouns.com. And to just like know that that is important and is an important fight, whether or not you feel supported in that.
Absolutely, and I think it's, so in terms of like, I mean, we are operating within multiple institutions that are very hierarchical. So learning how to talk up to authority is definitely a skill across any kind of issue, including this. And sometimes it helps to be kind of in that open way, like, why do you behave in this way? Why do you use that pronoun when we know it's this pronoun? You can be a little leading sometimes. But also I think it helps to have, to build up a coalition of support as well, to have other students or other colleagues who are supportive first, and then to maybe bring it up that way. As somebody who is now faculty, which is always surprising sometimes, I make a point of just correcting very quickly in the moment, and not doing my best not to make a big deal of it, and to not raise my voice, not to be angry about it, be like, actually no, their pronouns are he, him, his. Their name is Chris, and I know, and be like, I know what's on the medical chart, but like this is actually their correct name. So I just want to make sure that we keep doing that. And if you have any problems afterwards, feel free to just talk with me and just move on. And this comes up every so often within, for me, a clinical context or a research context, but happens less often if I correct it as it happens. Sometimes it's harder to do that after the fact. I think that's something to recognize as faculty and staff and people in some privileged position, to really exercise that power. And as Gray said, we don't know everything, and we have no way of knowing everything about everybody we interact with without asking. So I think being cordial about it is important.
Thank you. And some of the questions also address, and you mentioned this a little bit earlier, but if you could maybe reiterate or help elaborate on what are some of the best strategies for recovering from misgendering or unintentional blunders, particularly when people are afraid potentially of being seen as insensitive or perhaps committing a microaggression, and also in thinking about some of the non-traditional ways that gender might be expressed. So for example, in titles, using Miss versus Mrs. or Mr., a gender neutral way to address individuals that in that sense as well.
For me, I've moved away from using honorifics, gendered honorifics in general. So all of my communication with my patients is first and last name, correct first name, or correct name if it hasn't been updated legally just yet. And I generally just remove any honorifics for the most part. As a researcher, and those who might be familiar, when you have to submit like a journal article, sometimes they require an honorific, and sometimes their categories are expansive. A lot of times they're not. I message my authors and say, just so you know, this is what I'm limited to choose from for the time being. And maybe you and I can write a letter to the editor to make sure that they update this, but I unfortunately need you to choose one of these before I can hit submit. I think also in terms of just blunders, they happen. And I must say, for me, it's happening more with telemedicine, because sometimes I'm on the phone with somebody, and even though we've collected pronouns, it's taken a moment for me to adjust, or honestly, without being able to see them and see how their gender expression for me to even begin to start cluing in. If I've made the mistake of not asking, I've blundered. I'd be like, oh, my apologies. Correct me, what pronouns do you use? Great. And by the way, while you've said that, is it okay if I document that in the EHR so that it's updated there and that that this isn't an issue in the future? Recognize it will happen, but don't make a big deal. Don't like it's not the end of the world. And honestly, being able to apologize and correct yourself has the potential to be a significant rapport building with folks.
When we're talking about with students and colleagues, so say you misgender someone in a meeting, I found that a great way to address that is to, after the meeting, just send a quick email saying like, hey, I realized that I misgendered you, misnamed you during this meeting, sorry about it. And particularly because you have a second to read the email on paper and see what you're saying rather than trying to apologize in the moment, and you might have a lot of feelings around it and might get tripped up. So I think that's a good strategy.
I see, and I think there was a little bit implied in the question. I see one question in the chat, like how would you approach correcting somebody who's intentionally not respecting? after having a conversation with them, and if it persists, I think of it as a reportable incident, essentially, as somebody being deliberately disrespectful, which at minimum is unprofessional, at worst is potentially harmful to people. So I pass it up. I thankfully have not had that issue here. One of the reasons I'm happy to be here. Other places where I've been where I've had to pass it up, it just moves up the chain, somebody gets disciplinary action, and they move on, kind of thing. I think from my perspective within the health professions, I put this very much under our competency of professionalism, and to behave otherwise is unprofessional.
Thank you. And a few of the questions, again, you addressed this a little bit in the earlier presentation, but if you could also help expand on what are some of the best ways to approach initially asking a student or another colleague for their pronouns, particularly where folks might be interested, or folks might be, not wanting to make assumptions, but at the same time, this idea of potentially othering someone by asking for their pronouns as well, sort of potentially being perceived as, because I think you look different, this is why I'm asking, and how might someone approach a situation like that, and specifically doing so in a way that doesn't sound like you're pressing them for information or making them uncomfortable.
Gray, what's worked? What have you seen work?
Yeah, so there's a couple things. One, I think, is the points that Dr. Strudis made around just asking everybody and making it clear. I ask everyone this if that seems like the concern. Additionally, most of the time we're introduced to people. And so introductions, I think, really are a strong way to integrate this into our lives. So I think one of the most actionable takeaways from this is if you're in the process of doing an introduction within a Zoom meeting, which we all are often, is even if the people before you haven't introduced your pronouns, start introducing your pronouns in your introduction, because often all the people after you will. Yeah, I believe that. And yes, and give your pronouns first. So like if I'm introducing myself to someone, hi, my name's Gray, I use they and he pronouns, doesn't put the impetus on the other person. Thanks, Danny, for that.
Exactly, and I would, there's a mention about classrooms. I would think about including a brief passage about pronouns in syllabi as well. Essentially, I've seen some examples of this from colleagues where they essentially just say, just so you know, this is an aspect of how we respect individuals within our class environment, as it were, and including it there. Whenever I do larger meetings, will introduce if it's new people. I mean, I have many meetings with people I already know. We don't do pronoun introductions every time, but if there are new people, we will automatically just do it. I share mine. You can see my Zoom handle. I have it there. It's the same thing as that I have in a lot of my professional outward-facing profiles and such, is just have it there in the first place. And I can talk very specifically within the clinical context. I have a pronoun pin on my medical badge. I will introduce myself to patients like, these are my pronouns, what pronouns do you use, and kind of go from there. Or if it slips my mind for any reason, I just so you know, as I'm filling out your chart and we're trying to make sure everything is up to date, there is this part of your chart that we ask everyone, what are your pronouns, kind of thing. So there are a lot of different ways of couching it, but I think the best way you can do it is make it standard and make it second nature, essentially, with Zoom automatically pulls up my name with my pronouns. Makes my life a lot easier.
Something specific to BU regarding classrooms is that people's class rosters automatically populate with people's legal name that's listed with registrar. And so every single time someone who has a legal name that's different than the name they go by comes into a classroom, they have to tell a professor that. So just so that is known, that is not something that is automated at BU yet.
that's one of those situations too where I tend to prefer last name. And this is something we've changed a little bit in our clinical practices to avoid using first name if it's somebody we do not know immediately if that is the correct name.
Thank you. And to that point, there has also been a couple of questions where if someone does not want to assume and does not have the opportunity to ask directly, should they be considered the default, or is there a sort of gender neutral term if you don't have the opportunity to get clarification?
Yeah, I believe that generally they is a good default in those particular situations. I do want to make sure that it is clear that they isn't all trans people's pronouns, and not all trans people feel comfortable with they. So when people tell you their pronouns, those are their pronouns.
I was going to say the same thing. I have pretty much all of my automated communication is defaulted to they, and then can be updated once pronouns are filled in. And again, I want to remind people, you've been using they the entire time. You've been using your language. So this is not something, I want to remind people, this is not something that's new, but it's something that we can be more cognizant
of. Quickly, I think that often this feels like an arena where there are a lot of rules and people feel constricted by the number of rules that exist. And I'm here to tell you that there are 2 rules regarding trans folks. 1 is refer to us the way that we want to be referred to, and 2, unless it is directly relevant to your clinical practice, don't ask what's in our pants. And those are the 2 rules. Everything else is ask a person.
That's good advice for interacting with anyone.
Thank you. And then I know we are coming up on time. So if you have any helpful resources or tools for continuing in our knowledge and education in this area, do you have any recommendations? And particularly for folks who feel that the sort of expansive definitions of gender are constantly evolving, maybe some of the ways that people can also stay up to date and current.
So Gray had mentioned mypronouns.org. I dropped that link in. That's a really good overarching set of resources. Yes, the terminology is changing as the community gains more power in saying how they want to be called and such. I think is really a way to recognize that as things change, it's because people are able to speak up more for themselves and are given more agency. I think depending on what your work is, it's really your job to keep up with that language. I mean, as a clinician, I'm dedicated to being a lifelong learner. The way I learned how to treat diabetes a decade ago is not the way we're doing it now. So it is just part and parcel of how I have to update my practice. And that's how I see it. And naturally, as my work is very specifically LGBTQ focused and particularly trans focused, I try to make sure that it should be community informed. So that means using language that the community uses. That's the way I see it.
Thank you. Gray, not sure if there's anything you wanted to add as far as resources or tools.
There's nothing else particular that comes to mind. I want to reiterate the practice point, particularly people who feel uncomfortable using they pronouns. 1, you do it all the time, but 2, practice using them and use them with a friend. And on the newness point, it's not just new for you. We're all learning as we go, including people who identify in the ways that we're referring to. So we're all on this ride together and we're all learning together.
Well, thank you both.
And I just want to point out, I'm thankful to Gray for being here. I think it's another reminder in general, just as a member of the community, it is not any one person's job to represent everyone. Gray is an emerging expert on, is like an expert on this, but nobody should be expected to be answering for everyone. So I think that's something to remember. And I think that's the same thing in terms of the work that I do. Even though I'm asked to do this kind of stuff, I want to remind people that I can only share what I know and what people have shared with me, and that none of us are speaking gospel for everything.
Thank you both for sharing your expertise. Again, on behalf of the Graduate Medical Sciences here at the U School of Medicine and the School of Public Health, Queer Alliance, it was an honor to be able to connect with you on this very important topic. Just a quick reminder, this session has been recorded, so we will make this available for those who were not able to attend, and especially for those who might want to revisit some of the great resources that Dr. Street shared. And I believe we'll also be sharing the slides as well for attendees. So thank you, everyone.
Farah, can I make a quick plug as people are
Yes,
leaving?
yes, yes.
So the USPH Queer Alliance is sponsoring an event on Tuesday, which is the 27th, with Interact, which is an organization that is specific to intersex advocacy. So I linked the information in the chat if you're interested in that.
Awesome, thank you.
Thanks, everybody.
Bye, everyone.
Thank you.
Can you actually leave the meeting open for a second so I can grab that Zoom link information?
Yep, sure.
Thank you.